And we'll get started. So you can all see Dr. Roswell on your screen there. I want to welcome him and thank him again for doing our talk today on advancing health equity and working toward a more just healthcare system. Dr. Roswell is a leader in advancing diversity, equity, and inclusion in medicine. His work in this area includes influential studies and talks focusing on the impact of implicit bias on disparities in healthcare access, delivery, and outcomes. He's an associate dean for diversity, equity, and inclusion, and associate professor of cardiology and science education. And he oversees the recruitment initiatives, pipeline programs, innovation, and enhanced medical curricula to build toward health equity and inclusion at the Zucker School of Medicine at Hofstra in Northwell. It's quite a mouthful. Dr. Roswell received certification as a healthcare executive for diversity and inclusion from the Association of American Medical Colleges. He's a nationally recognized authority, both clinically and academically, serves as an officer to the board of directors of the American Board of Internal Medicine and chairs its Committee on Diversity, Equity, and Inclusion. He's also a member of the American College of Cardiology Board of Trustee Health Equity Task Force and a member of the Association of Black Cardiologists. He was a member of the inaugural steering committee of the Critical Care Cardiology Trials Network. And last but not least, in his spare time, he is co-director of the Cardiac Intensive Care Unit and associate director of the Cardiology Fellowship Program at Lenox Hill Hospital, part of Northwell Health. Dr. Roswell has been recognized by the American Heart Association and by the Student National Medical Association for outstanding mentorship and appreciation. And we have no more time now for your talk because your accomplishments are so lengthy. I'm of course kidding. So with no further ado, I'm going to turn the floor over to you, Dr. Roswell, and just remind attendees, if you have any questions, I'm monitoring the chat. Your microphones are muted, but I will be looking at the chat and I'll pass any questions on.
Absolutely. Thank you. And this is a true honor to talk about health equity with this group. And it's also always staggering when you hear your introduction to believe that I'm doing all those things. And again, true honor. So I would welcome everyone to actually put in your questions in the chat. There is a video that we have in this presentation, so I hope you're able to hear it. We weren't able to test it out, but let's get started, and fingers crossed that the video will work. Maybe Teresa, you'll just give me a thumbs up when we get to the video part. If folks can't hear it, then I'll narrate through that particular part of the session. And so hopefully that you can see my screen here.
We can.
And that you can see the slides here.
Yep.
Great. So we'll talk today about health equity and advancing health equity. I thought it would be really important to first start off with level setting. We're talking about definitions of health equity, health disparities. Then we'll go through examples of health disparities. And then we'll talk about some bias, racism, health equity research, healthcare economics and how that intersects with health equity. And then we'll finish off talking about next steps. But please feel free to put questions and comments into the chat so that we could have a robust Q&A session. I will start by just level setting us in terms of the words that we use, and this is to sort of advance equity and health equity in healthcare, and just to go over some of these principles of equality versus equity versus justice, what that actually means. And equality is making sure everyone has the same thing, and they're the same height. And you can see in this figure, they could all try and reach that apple on the tree. They're the same height, they're equitable heights. The way I translate this is to health insurance or pharmaceutical reimbursement, like health insurance, making sure that everyone has health insurance is equality. And so in this country, we don't even have equality, but we actually are talking about equity. Let's say those with health insurance and they have some means of getting health care, or those who have reimbursements or some pharmacy insurance. Equity is making sure that you meet people where they are. So if they have the pharmacy insurance to get medications, someone who's making $50,000 a year or $20,000 a year and their out-of-pocket costs are $200 a month, it's not the same as somebody making $150,000 a year or somebody who's making $1 million a year. So equity is making sure that we adjust that out-of-pocket cost based on people's income and how they're able to afford it. And that's the principles of equality, giving everyone the same thing, versus equity, giving people the appropriate things that they need for their own individual circumstances. And then justice is where we get to a level playing field, that everyone is on the same playing level, they're same height, they can reach the apple in that tree, and that's our overall goal, is to get to justice. And so I can tell you, on the American College of Cardiology, we had a health equity task force, and we talked about definitions. And we said, if we're going to publish about health equity, let's actually talk about what it means. And we had a robust conversation of what it actually means. And we started with health inequities. What are these? What is a health inequity? And it really is this systemic, avoidable, and this is important, that inequities are avoidable. They're unjust societal factors, structural practices, including racism, that create barriers and to opportunity of healthcare and result in avoidable adverse health status and outcomes. And that's the key phrase there: avoidable, unjust societal factors. And then health disparities come from those health inequities, where you get adverse health outcomes and health status that's attributable to avoidable and unjust societal factors. And then health equity, we talked about this for a while in our meetings. We said it actually is a human right to allow everyone to achieve their best attainable health outcome by overcoming all avoidable, again, avoidable barriers. And we put that and we published that. And as we were publishing that, and we see a lot about healthcare and systems talking about health equity, and it's spilled over into mainstream society talking about equity, we started seeing a couple of things, and we started seeing people talking about, stop critical race theory, talking about racism is hateful. And then we saw this from the Wall Street Journal, that medical education is going woke, that doctors will be obliged to learn about systems of oppression, and they won't know how to take care of your diabetes, but they'll learn about systems of oppression. And this has really spawned the, big anti-DEI era that we're in right now. And I'm glad that the president of the AMA really wrote back to the Wall Street Journal editorial board and said, no, it's important to make medicine anti-racist. And what we did at the American Board of Internal Medicine, we went as far as to say is, we are the body that certifies physicians all over this country, and you need to know about health disparities and health equity to adequately take care of patients. And we think it's really important. And I want you to pay attention to these next slides coming up of why it's important, why it's not woke, it's what is right to do. And this is looking at maternal mortality in the United States. And you can see total maternal mortality if you look at non-Hispanic whites, where it is, and I think this is at 2020, looking at it here, and then you see non-Hispanic Black. And this is actually worsened, where it's 7 times worse for maternal mortality for Black birthing people compared to white birthing people. And again, maternal mortality, looking at that increased rate, it's not being, I think, woke or very left wing. It's just straightforward taking care of lives. Why are Black women dying around pregnancy 7 times the rate of white women? And we have to figure that out. We have to solve it. And it's what I think all physicians would want to do, and what all of us in society would want to do, is to figure out how we lower those rates. Again, not being particularly woke or anything else. And this is a little bit of a complicated slide, but what it's showing you here is that this is pulse oximetry, which is how you measure the oxygen based on waveforms. And we put that on either your finger, or your thumb, or some part of the body. And what this is showing us here is that pulse oximetry actually overestimates the actual oxygen content in Black skin because of melanin and how that particular technology is designed. So why is that important? Is because when we had COVID-19 and we were in the throes of the pandemic, there were delays in delivering care to Black patients because the pulse oximetry reading was too high. And this is why it's really important to figure out, where race is in medicine, how we're developing technologies, are they accurate for everyone? Because if they're not, the publication down here talks about the delay in identification of treatment eligibility because of those faulty pulse oximeters. And people did not get treated the way that they should have because of that. And it was just because of their race that the pulse oximeter wasn't designed appropriately for them. And these are things that we're talking about in medicine in terms of health equity. And again, I don't think these are particularly woke, philosophies. These again just trying to make sure that we're treating people equitably and actually making sure that we're saving lives. The same thing that happens when we talk about health equity, we talk about rural versus urban disparities. We know that if you look over the time here in the graph, that rural and urban in terms of mortality were on par. But what happened is that as we have innovation, a lot of that innovation has gone to urban centers. And we see that there's a divide now in terms of how mortality is continually decreasing in urban centers. And you see in rural parts of our country, it sort of plateaued. And what we do in health equity spaces is to figure out how we can make sure those who live in rural communities could actually benefit from the same thing that those of us who live in urban parts of the country can benefit from, the innovation, the technology. And this is what health equity is about. Health equity is also studying differences that we see in gender. So I'm a cardiologist. A STEMI is a myocardial infarction, a heart attack. And so when people are having an acute heart attack because of a blockage in a blood vessel, what I did with some colleagues is study that women were dying more than men in this particular condition. And when you have a blood clot that's obstructing your blood vessels, the time that you have to open up that blood vessel is very important. And we see that for whatever reason, that women, when they present with these symptoms of having a heart attack, the time that they take to get their blood vessels is much longer than men. And we look at that and we're trying to figure out why. And we hypothesize that some have to do with not recognizing heart attacks really affect women and the bias that's involved when we're looking at these things. But that bias, when women don't get taken seriously for symptoms of a heart attack, translates into death. And this is critically important. And again, this is what we're looking at in terms of health equity. How do we reduce mortality with women and heart attacks? How do we make sure that the healthcare enterprise is not biased when women are presented with symptoms of chest pain, that they get taken seriously, evaluated, and again, don't die? Bias is, I always think of it as it's pervasive. We all have biases, but I think there are certain jobs, careers, specialties that bias is critically important. Healthcare is one of them because if you are biased, people may die because of your biases. Same thing with law enforcement, in the judicial system. When you're biased in those situations, that really has a tremendous impact on people's lives. And this is just a quick study that was done it was done back in the late 1990s and looked at predictors for referral for heart catheterization. That's to see if you have a blocked blood vessel to the heart. What they did in this study is they trained actors and they went to doctors and they had the same script. And the right answer at that time was that they needed to have this procedure, the cardiac catheterization, to open up their blood vessels. They all had the same script, the same story. And there were, women, men, white women, white men, and you can see all of the actors, some of them are portrayed there. What happened in this study, as you can see, is with the same exact story of symptoms, men were referred more than women. white patients, the actors were referred more than Black patients. And when you take the intersectionality of the two of those, Black women were referred less than all of the other combinations. And again, this is the same exact story to doctors, and the right answer or the right path was to do a cardiac catheterization. And so we see how bias affects people and how it affects patients, how it affects the healthcare industry. And again, the downside is people don't get procedures. They die when it comes to healthcare. And this is really what health equity is about. It's saving those lives. And while we're talking about bias, I just want to introduce you to Ms. Coverdale. And Ms. Coverdale really does a lot of work with us at the medical school here about teaching our students the impact of implicit bias. So she lives in Long Island, the eastern part of Long Island. And when the pandemic hit and the first wave, she was very sick. Her husband was hospitalized and he was diagnosed with COVID, and she was very, very sick. She barely can breathe, and she was trying to get to the hospital. And every time the EMS would come with those pulse oximeters, they would tell Mrs. Coverdale it was too high. She had to stay home, and she was coughing up blood. She can barely speak. And they went over and over to the emergency room. And I think on the fifth try, with the help of some doctors, they were able to accept her and admit her to the hospital. She thinks, again, it's because of that pulse oximeter that I told you about before that's faulty, the one that goes on your finger, which is what delayed her treatment and services. This video here, and I hope it plays, so Tricia, just let me know if I get a thumbs up if it's playing. This video talks about what happened in the hospital with her husband. And so her husband was treated in the ICU where I work for critical patients. And at that time, we didn't know how long you need to stay in the hospital. Everything was up in the air, and he was still in isolation, and he couldn't sleep because of the bells. And he asked them, please, can I get maybe a sleeping aid or something else? Staying in this hospital room is really not doing well for my mental health. I just need to maybe sleep, or can I get something to relax me in this particular condition? And so they called the psychiatry consult to help him relax in the hospital, and this is what happened. And so Teresa, just let me know thumbs up if we could hear the
I
sound.
would make much better progress at home where I have familiar surroundings, and here the only thing here is the television. I'm a person like you. I'm educated. I have thousands of books in the library that I could consult. I need more stimulation than this, and someone around me who's gonna, not keep me in the dark and what have you. Well, the doctor went out based on that conversation and indicated that he had dementia and put him on the dementia ward. And we had to actually intervene and talk to a doctor who knew him outside of the hospital, knew very well that he didn't have dementia, and to get that diagnosis taken off of his medical record. And when he tells the story now, he says he believes it was because that doctor did not expect a Black man. He did not know my husband, did not know of his background, did not know that he was a former college professor, that he pastored a church or anything else. All he knew is he's a Black man who said that he had 3,000 books at home. He must be crazy. So, again, we can talk about all of the systemic antecedents and contributing factors, but I think that if we're going to have a real in-depth conversation, we need to really understand that the systematic entrenched racism also leads to widely accepted behaviors of implicit, sometimes explicit bias that impacts us as Black people and brown people, that have disparate impacts because of it. So I think these conversations are wonderful. I think that without them, without unpeeling this onion, we'll never get to the bottom of it, and we'll never be able to heal.
So I always thank
This
Ms. Coverdale about, really talking to our medical students about, that experience in the hospital and how, Reverend Coverdale, who's a pastor, and Reverend Dr. Coverdale, and he was referred to the psychiatry unit because he mentioned that he had several thousand books at home and he rather go read books at home than stay in a room and maybe he can convalesce at home. And it turned into quite of an ordeal. And you can imagine for patients, anyone who's sick and going up against these struggles, how that must wear on your recovery, your perception of the healthcare system, and everything else. And so maybe I know Teresa's monitoring the chat, but maybe at some point, maybe now you could just maybe just put in the chat and we could talk about it later. Just some of emotions or reflection that particular story brings up for you while we go on and talk about the types of racism. And I just want to do this because we're going to talk about health equity research, and I want to make sure that you have the framing. And so these are the four levels of racism. Really looked at the director of equity in the center in that center. And I think these types of racism are important because people talk about racism and believe it's really just the personal and interpersonal parts. And that was the old framing of racism that, let's say, if one was part of the KKK and they believed that white people were superior, that they can take out that action against Black people, or whether it's in stores or wherever in society where there is some expression of racism, like you can't enter the store, like the Jim Crow era. That's what people think about racism. But sociologists really have moved past just that interpersonal conflict and private ideas and just and personal ideas. They look at that as institutional as well, and structural or systemic. And institutional is where the discriminatory treatment and policies actually are in an organization. And structural is when you have it in the organization, but it's in policies, it's in practice norms. It gets all sort of permeated through society, and it's systemic and it just lives out there in society. And so people, I think, talk about, well, is there systemic racism? Where is it? And that's the problem with it because it's everywhere, and people sometimes don't understand, what do you mean? Is it everywhere? Like, am I particularly racist, or what do you mean? And it's the system, because if you have those policies and practices, they start to build on one another and then they perpetuate systems and output of racism. So one example that's really famous is institutional racism in the real estate market. And I just give this as an example where this is the same home. It was a Black and white couple, and the Black wife was home when the appraiser came by for their property, and it was appraised at 330. And the couple knew that most of the houses in their neighborhood went between 450 and $500,000, but 330 was pretty low. So what the Black woman decided to do is take away all of the pictures and have her husband stay home, and he was white. He came back, different appraiser, appraised the property at 465. And so again, you can see institutions like real estate or banking, when it comes to loans, when it comes to specific thing, how racism and practices and beliefs sort of have their effect. And then it has a downstream effect as well. And so we'll talk about what that's institutional racism, but we'll talk about structural, which is really legitimization of an array of dynamics. So it's historical, cultural, institutional, political, interpersonal, all of it that keeps on producing cumulative negative outcomes. And I think this is a great definition by the Aspen Institute. It's difficult to locate because you can't find it. You can't put your finger on it and say, this is exactly structural racism, because it's the norms of the past coming into the present, and it keeps on creating new forms of racism. And it's really the most profound and pervasive form of racism. And all the other forms emerge from this. And I can tell you another example people talk about is environmental racism, where because of policies, certain groups are relegated to live in certain neighborhoods. And then those neighborhoods that are predominantly Black and Latino turn out to be exposed to toxins. And then they come into the healthcare system, and we can see that they have a higher rate of cancer, higher rate of mortality because of what's going on in their environment. But what happened, what caused them to be in that environment is because they were relegated because of the banking policies, the loan policies, and all those things came together and had that group there. And so that was an example of how structural racism works, and it creates new forms of racism that we name and identify later on. And so I mentioned structural racism and its effects to show you a quick example of what we did here at Northwell in looking at what happened in the first wave of the pandemic. And so hopefully you can see my arrow here, and that this is a map of New York City for those who are not familiar, that this right here, if you can see, is Manhattan. This right here is Brooklyn at the very part right here where I'm circling. This right here is Queens, where I'm circling, and then this is Staten Island, and then up here is the Bronx. And so what we did, this is the first wave of the pandemic. And what we did is look at these, all these, don't look at the numbers yet, but all these squares are zip codes. And what we wanted to look at, because in the hospital, we saw that people were dying from COVID-19, but what was happening outside of the community? What was happening to people who didn't make it to the hospital? So we actually took the rate of people who were out of hospital death and went to the fire department and got their data and looked at it in 2020 compared to 2019, and then used that as a ratio to see how much more were people dying through the COVID pandemic. And you can see, like, for example, in this neighborhood in Staten Island, it was 1.35. And so the blue you can see is these are people dying at an increased rate of 1.35 in Staten Island. And when it gets to the clay colored and red, it gets higher and higher. And you can just look at the numbers here. You can see that there's neighborhood where people are dying 13 times. The highest was here in Queens. This neighborhood was dying almost 20 times, and this other neighborhood was 1.67 times. And so a group got together and said, why are these people in these different neighborhoods dying at these drastically different rates across New York City in the pandemic, in the first wave of the pandemic? And we know social factors really contribute and structural racism. So we figured out how are we going to study that. And so we looked at all these social drivers of health, like education, income, access to healthcare, all of those things, the social factors, and we put them in a multivariable analysis to see what was driving these differences. And this is a complicated chart here, but the main driver that we saw were two things: education, proportion of people who had less than high school education in those neighborhoods were driving people to die in the first wave of the pandemic. Also, the proportion of Black race in those neighborhoods were also associated with people dying in those neighborhoods. And the proportion of people that were Black race dying in those neighborhoods didn't necessarily have to do anything with their biological race. It had to do with structural racism and the impact. And people are talking about weathering on people of color and what that does to your DNA, what that does to your body's chemistry profile when you're discriminated, targeted, you feel you're under resourced. There's a lot of data right now that shows that actually weathers your system, causes increased mortality and other negative health outcomes. But this is what we found: is education. Education was the main driver. And I don't want to say I was happy to find this, but I was glad that there was something that we can do. We can change education structure in New York City that can protect people, that they know about, like what a virus is, how to get to the hospital, and all those other things. And education is the gatekeeper to a lot of downstream benefits in society. And we also could change weathering from Black folks, and that's taking away all of the structural racism, interpersonal racism. I think we could do it as a country if we think about it. I think an easier short-term fix might be the education. So we published this in Circulation in Arrhythmia and Electrophysiology. And I talk about these disparities, and this is just shifting on to spending and healthcare finance. I talk about these disparities because, as you know, we spend about $5.4 trillion on healthcare in the United States. And if you look at this, this is the United States, how much we spend per capita on healthcare. And this is life expectancy, which you can see here. And you see where we are. We're like a lonely island out here. And Western Europe is all the way here. You can see some of your favorite countries. You can see Japan. Look at Japan's life expectancy towards how much they're spending per capita. And you see the UK, you see Germany, you see, you know, Poland here, Mexico at 75. And look at how much Colombia and Mexico are spending on healthcare and what their life expectancy is. And look at what we're spending, right? $5.4 trillion. And we spend so much compared to our Western European allies and colleagues, and look at what we get. And this is just life expectancy. You do anything, death compared to people not having health insurance, maternal mortality, all of those, infant mortality, most any marker of health, and we are at the bottom of the list. But we are at the top of spending. We're at the top of spending. And why is that? A lot of it is due to, and again, we won't get into the pharmaceutical costs and all of that, but a huge part of it is health inequities. So this is from Deloitte analysis looking at the cost of inequities when people have to go to the ER and they don't have that primary care, preventive care, and they use the acute inpatient system, and what that does, and their disease processes are much further along. The cost is estimated at $320 billion in terms of what health inequities are costing us. And projected, if we don't do anything about it, it'll be by 2040, it'll be $1 trillion. And so I always bring these figures to show what we're doing, why it's so important. I think it's important ethically, but it's also important from a fiscally solvent healthcare system. And if you look at CMS, and we won't go through the framework here, but I know I'm talking with IPRO, and you know about and CMS is really involved with looking at health equity. And first is like looking at the collection, reported, and standardization of data. But all over the government, we see how important it is to really stamp out health inequities, because it's so costly. It is just about people dying unnecessarily, which is the whole point of this. And I just threw this in as well in terms of the fact that we spend the most on healthcare, but we spend the least on social care. And social care is critically important to actually solving those health inequities. When we did our analysis, we looked at social markers, and that actually impacts much more of your health outcomes than, well, what I do as a physician with you in the ICU or in an office practice. This is a quick slide as we wrap up pretty quickly, just talking about health outcomes and how much states spend on social care. And so you can see if you're above that line, you're spending more in social care. And if you're above that line, you have better metrics in terms of obesity, asthma, mental health, days activity limitations, mortality from lung cancer, heart attacks, and diabetes. It is pretty clear that the more you spend on social care, these social determinants or social drivers of care, that actually reduces mortality and morbidity in population. And so how do we move to that model where we're looking a little bit more of social care in our healthcare delivery system? And I'll end up with these last two slides as we take some questions. And I'm not sure if you're familiar with downstream versus upstream interventions, but this is from public health. And the story is that some person sees someone drowning in a stream and they pull them out of the stream. And then they see another person drown in the stream and they pull them out of the stream. And then all of a sudden, like the whole group of people, there's another person who's in this stream, and they figure out exactly how to pull these people out of the stream. And then they create these elaborate mechanisms to actually pull people out of the stream. The whole town's involved. And then someone says, what's going on upstream? What's causing these people to fall in this stream? And so upstream is looking at more structural policies and practices that are causing downstream consequences. And so I think to really solve health inequities, we have to look at the policy level. We have to look at how social care is integrated into and healthcare. But then we also have to figure out the downstream problems that we have in terms of bias and awareness and trust and making sure people have access to care. And I think that dual pronged approach will get us in a better situation. So I'll wrap up with the take home points here is that I hope I have convinced you, and I hope that you can actually spread the message to others who are asking, who think equity is some, I think, abstract concept. You could really explain to them that actually health equity is about saving lives, and it's whether you're a Democrat, an independent, if you're a Republican, we are all in the business of saving lives. And also health disparities are quite costly. It will bankrupt our system. And a great way to move forward is really integrating social care into the redesign of healthcare. And so there's a lot of folks who help me out with these research projects and talks. We're all a big team. And so I always thank them here at Northwell, at the American Board of Internal Medicine, at the American College of Cardiology, for all the support in doing healthcare and health equity research and to be able to do presentations like this to you. So thank you for your time and attention, and I will stop sharing and we can have a Q&A session.
Yeah, thank you so much. That was really fascinating, and I'm seeing lots of comments. So Lynn Wilson, when you asked about how was it Mrs. Coverdale?
Hey, Mrs. Coverdale.
Yeah, Lynn says makes me angry and disappointed, and I think she's probably speaking for many of us. If anyone has a question for Dr. Roswell, if you can put it in the chat, feel free, or I can try to unmute you if you want to speak. We've got 137 people on the call, so I'm sure somebody has something to add. In the meantime, I'm going to I can unmute Tier.
Dr. Roswell, thank you so much for doing that. I learned a lot, and I think you did a great job of really explaining, the social determinants of health and how equity can save lives in a way that can help us look at our work at IPRO differently. I do want to say, this is a wonderful addition to our anniversary, our 40th anniversary activities this year. IPRO turns 40, and we want to also celebrate the diversity and cultural mosaic of our staff and the people that we serve. And you have helped us do that greatly with this understanding that, no matter what contributions an IPRO employee makes, we're all working towards the same goal of saving lives. So we appreciate you for your efforts, for the staff that are participating. We are so happy that you took the time to do this and to look out for more celebrations of the cultural mosaic of IPRO and the people that we serve as we continue on our journey towards celebrating the 40th anniversary. And I'll stop there. I don't know if anybody else has any questions, but I do see quite a number of positive comments about what you've shared with us today. So thank you so much.
Absolutely, and I appreciate your comments, and this is really, and it was a short condensed version because I know this is over lunchtime and we had about 30 minutes and then some time to chat. But I think it's so important, particularly in this climate where everything is politicized and polarized. And there's one thing that I think when you look at the data presented here is that this shouldn't be politicized. This isn't polarized. This is just period saving lives. And I really wanted to get that across to folks. And as people talk in their communities and their circles, when you hear, equity is bad, it's woke. I'm hoping that folks could really chime in and say, well, actually, health equity is about just saving lives, and that's not bad. And I really wanted to make sure people have the resources and the skills to spread the knowledge that what we're doing is really just like saving lives. We're not doing anything that's left leaning or right leaning. It's just kind of central to saving lives in this country.
Mhm.
Well, thank you for that message and for taking the time to speak with our group today. And I want to remind everyone that we will be posting Dr. Roswell's presentation on IPRO Connect. So if you want to come back and watch it again, or tell your coworkers about it and have them give a listen, it will be available there. That will wrap it up. Thank you everyone for coming, and enjoy the rest of your day. Dr. Roswell, thank you again on behalf of all of us at IPRO.
Thanks so much. Bye-bye.
Thank you.